Hello, I'm Dr. Sanjay Patel. I'm a corneal transplant surgeon at Mayo Clinic in Rochester, Minnesota. We have had an active research program in corneal transplantation outcomes and Fuchs endothelial dystrophy. In this video, I'd like to tell you about a recent study examining quality of life after keratoplasty for Fuchs dystrophy. This work was supported by Mayo Foundation and Research to Prevent Blindness. So for a little background, Fuchs endothelial corneal dystrophy is a complex genetic disease. We're learning more about the genetic work right here at Mayo Clinic. The disease is characterized by loss of corneal endothelial cells, formation of guttata, and eventually development of corneal edema. And this affects vision and becomes a leading indication for corneal transplantation. Over the last decade, we've had a significant revolution in how corneal transplants are performed, beginning with the traditional penetrating keratoplasty and undergoing a series of iterations of endothelial keratoplasty, from the original DLEC, deep lamella endothelial keratoplasty technique, to Decimé stripping endothelial keratoplasty, or DSEK, and now to Decimé membrane endothelial keratoplasty, or DMEK. So the purpose of this study was to determine vision-related quality of life in patients with Fuchs dystrophy. And we specifically looked at three techniques, and that was PK, DLEC, and DSEK. So we designed the study by recruiting patients from our service who had Fuchs endothelial dystrophy. There were actually two studies here. The first was a DLEC versus PK randomized controlled trial. The enrollment period was 2004 to 2006, and patients had to have a best-corrected visual acuity of 20/40 or worse at entrance. These patients were randomized to PK or DLEC, and were then followed after surgery. In a second consecutive study, which was a prospective observational study, we enrolled patients to DSEK between 2006 and 2009. These patients did not require an entrance best-corrected visual acuity. After surgery was performed, patients were examined again at 6, 12, 24, and 36 months after keratoplasty. The primary outcome was vision-related quality of life measured by using the NEI's Visual Function Questionnaire 25. We also measured best spectacle and uncorrected visual acuities using electronic ETDRS methods, keratometric cylinder, and disability glare. As you can see from the table, the surgical procedures varied in their incision size. Penetrating keratoplasty typically had a graft diameter of around 7.5 to 7.75 millimeters. For DLEC, we performed limbal incisions 9 to 10 millimeters across. All grafts were prepared manually except the two that were prepared with a microkeratome. Graft diameter was slightly larger than that of penetrating keratoplasty, and the graft was inserted unfolded on a spatula. For the DSEK cohort, we used a smaller incision, 5 to 6 millimeter limbal incision. All grafts were prepared with a microkeratome, and graft diameter was slightly larger at 8.2 millimeters on average. These grafts were folded and unfolded in the anterior chamber. For eyes that had a cataract at the time of surgery, the cataracts were removed through the same incision, whether it be open sky or by using phacoemulsification for the endothelial keratoplasty techniques. For statistics, we use paired t-tests for comparisons over time, analysis of variance, and student-Newman-Cool's procedure for comparisons between groups. And we had to adjust for age, sex, visual acuity of fellow eye, and other events with respect to the vision-related quality of life data. Correlations were determined using the Pearson technique. Here are the subjects in each keratoplasty cohort. For PK, we had 12 subjects, for DLEC 11, and for DSEK 40. Mean age was similar between groups. Distribution of males and females were also similar. We also had similar preoperative lenticular status, and the visual acuity of the fellow eye also happened to be similar. So despite these being two different studies. The preoperative criteria were very much the same. As we follow this cohort through 1, 2, and 3 years after keratoplasty, we can see continued improvement in vision-related quality of life, such that at 3 years there was actually no difference between groups. When we compared 3 years to 6 months, we saw significant improvements in the PK and DSEC group. The VFQ-25 also allows us to measure various subscales. Prior to keratoplasty, there was no difference between any of the subscale domains between the 3 groups. There were transient differences after keratoplasty. Of note, at 3 years, ocular pain was reported to be worse after penetrating keratoplasty than after DSEC, and driving was reported to be better after DSEC compared to DLEC. Here are the visual acuity results with best spectacle visual acuity and uncorrected visual acuity. The Snellen equivalents are shown on the left side. What you can see is that visual acuity improved after all keratoplasty techniques, but the vision improvement was fastest after DSEC with respect to uncorrected acuities. At the 3-year time, visual acuity was actually worse after DLEC compared to PK or DSEC, which were remarkably similar. Uncorrected visual acuities were also remarkably similar between groups at 3 years. The keratometric cylinder, it's no surprise that the PK group had much higher astigmatism after keratoplasty compared to the endothelial keratoplasty groups. This remained relatively constant in the postoperative period. So what are the factors associated with quality of life? In Fuchs dystrophy, that is before keratoplasty, quality of life was correlated with the recipient age, such that quality of life was actually worse in younger subjects. Quality of life was also correlated with visual acuity in the fellow eye, and this has been previously reported. After keratoplasty, the improvement in quality of life was inversely correlated with age at 6 months and at 1 year after keratoplasty, meaning that younger patients had a bigger improvement in quality of life than older patients. In this table, we can see correlations between the various optical parameters that were measured and quality of life. What stands out here is that uncorrected visual acuity appears to be correlated with improvement in quality of life throughout the postoperative period, whereas best corrected visual acuity was only correlated with quality of life at 6 months. At 3 years, we can see that intraocular stray light, which is a measure of disability glare, was also correlated with quality of life. So there are limitations to these studies. The first is that there were actually 2 studies here that were consecutive. The first study, remember, was a randomized controlled trial. The second was a prospective observational study. The sample sizes for the PK and DLEC groups were smaller, much smaller than the DSEC group. We also had 10 subjects that had fellow eyes operated during the study period, which might have affected quality of life outcomes. But when we examined this, all subjects were operated on beyond 6 months after the first eye, except for 1, and the greatest improvement in quality of life happened in the first 6 months. So in conclusion, vision-related quality of life in Fuchs dystrophy is decreased compared to normal healthy subjects, where one would expect a composite score greater than 90. It's also worse in younger subjects and in those with worse visual acuity in the fellow eye. After keratoplasty, vision-related quality of life improves irrespective of which keratoplasty technique is used. The improvement is fastest after DSEC, but at 3 years there is no difference in quality of life between subjects having any type of keratoplasty examined. The improvement is much higher for younger patients, and the improvement is associated with better uncorrected visual acuity and lower disability glare. So what are the implications of this study? Well, in this era, it's important that we measure patient-reported outcomes, and this study, by by measuring patient-reported outcomes, supports endothelial keratoplasty as the treatment of choice for Fuchs dystrophy. It's also going to be important for determining the overall value of the newer DMEC procedure compared to DSEC as keratoplasty continues to evolve. And by measuring patient-reported outcomes, we'll understand whether there is actually value gained over the long term for patients' quality of life. I'd like to acknowledge my contributors, Eleanor Truesdale, who was a medical student at Mayo Clinic, who worked on this project extensively, David Hodge, who helps with the statistics, Keith Barretts, Leo McGuire, and Bill Bourne, who are my fellow corneal surgeons at Mayo Clinic. I'd like to also acknowledge Research to Prevent Blindness and Mayo Clinic for their support. Again, I'm Dr. Sanjay Patel at the Mayo Clinic in Rochester, Minnesota. Thank you for listening to this presentation.